Hi, I'm Duncan Sanders. I'm a senior lecturer at the University of Sydney on the pain masters, and I'm also a pain physiotherapist, and I've done that since 2002.
Hi, I'm Flavia. I'm a senior lecturer at Curtin University and Curtin Medical Research Institute. I'm a teaching and research academic, and I also trained as a physiotherapist.
Thank you for coming, Flavia. It's a great honour to have you here and talk about your research. First thing I think as physios, just is there any difference between upper limb pain and other pains like neck pain or back pain?
I think this is a really important question, because while I can absolutely appreciate the importance of us talking about the brain and the central nervous system and it being crucial in the construction of a pain message, I think what might be lost along the way, what could potentially be lost along the way, is the important differences in different pain conditions. So even though we can talk about pain generally, when we're talking about different conditions, there's really important differences that I think we can't lose sight of. And I personally am really interested in pain when it strikes a limb. We think of complex regional pain syndrome being the most stark example of that. And in order to be diagnosed with complex regional pain syndrome, one needs ongoing pain that's disproportionate to the inciting event, but also a series of signs and symptoms across many body systems. And that's what gets the diagnosis. Chronic back pain, chronic neck pain doesn't have such a huge sort of plethora of things that need to be ticked off in boxes before that diagnosis is given. So already I think we're dealing with a great complexity and a really multifactorial picture when we look at limb pain.
Yeah, and with CRPS maybe particularly, what are the sort of stark differences and mechanisms that physio should be aware of? Because it presents clinically as quite severe, and as a physio, people can get quite worried about it or not know where to start. So from a basic point, mechanistically, where would you say the differences are, and then how might that relate clinically?
I think the fact that CRPS has changed in its names and changed in its subtyping and definitions so many times over the years shows how complex and confusing it is. But one thing we can be sure of is that the signs and symptoms across sensory, motor, all those temperature changes, everything, all probably need that attention. And there's certainly, when we picture a CRPS, someone living with CRPS, there is that really florid presentation that comes to mind. So definitely still tenets like graded exposure and education for empowerment for people. But I think addressing each of those body systems is probably of great importance. I don't treat anyone clinically, but what I can say is that it is hugely complex. It does seem to spread in funny ways, just as a matter of interest. It is called complex regional pain syndrome because it affects a region, but not just one region. It can spread, it can move around, and it doesn't seem to respect those peripheral nerve territories that we know from the textbooks. So we don't even really call CRPS type 2 neuropathic anymore because it's not even respective of a single nerve territory. It can move around and spread in funny ways. So loads of listening, loads of testing to really understand what it is about that person in front of us, because it's going to be so different to the next CRPS person that might come through the door.
Interesting. I suppose that's not just mechanisms, is it, from a bio, but it's also people present differently psychologically, socially.
Absolutely, yeah, and we're seeing that at this conference. We're seeing extraordinary talks on mechanisms from cellular level or molecular level. We've had great talks on systems, as in the ones we work in, and politics and healthcare, and the fact that comorbidity, it's probably a misnomer, isn't it? Because people don't just present with one or two extra things every now and then. It's an exception to come across someone who just has pain.
Which is a big limitation of the research, I imagine.
Absolutely.
Which is we exclude people on drugs, people with this, people
absolutely.
with that.
And in limb pain, that's extra pertinent. So many papers we come across, and understandably so, because CRPS is rare. It's hard to recruit people. They may have simply compared to the other side, or they may have only recruited right-hand affected people or right-hand dominant people. And so that already raises questions, doesn't it? Because all those things can have different effects or different ways of playing out with our hugely complex central nervous system.
Yeah. And you talked about the diagnosis criteria. Can you just run through that clinically, what physios might find useful, and then what you think the limitations are and where it maybe should sit?
So we have signs and symptoms across the sensory system, the motor system, and then we look at things like edema, we look at colour changes, we look at any hair, skin, nail changes. They tend to come on a little bit later in the more severe cases. But there's signs and symptoms. So as with anything, we've got to listen, because what we're seeing in clinic may not be what that person needs to tell us about what they experience the rest of the time. A cool thing about the updated, Valencia adaptation of the CRPS diagnostic criteria is the introduction of a sort of CRPS in remission category. So just because I'm seeing Duncan in front of me right now and he doesn't have all the signs and symptoms he had in the past, he might be missing a couple, but I'm not going to rule him out as not having CRPS. I might just put him into that other subtype where I'm just going to sort of watch and act in a way. But yeah, it's across all those different categories. I argue that particularly in the case of the somatosensory nervous system, where I myself have done research and had the most interest, I'm not sure that we can simply just compare to the unaffected side as comparison, because some pretty interesting things happen interhemispherically in the brain, some pretty interesting things happen to tactile precision on the other side of the body, even if that other side doesn't maybe meet diagnostic criteria for CRPS as well. That adds more complexity than anything else, because then what do we compare to? Because every person is different, every limb is different, but I don't think we can simply call a healthy side and use it as our baseline. Raises more questions than answers, yes. But that would be something I'd be keeping in mind.
So where would you suggest going with that?
I think it's probably really pertinent to take into account the subjective side of someone's story, the symptoms they report, because I don't think anyone's rushing off to the physio for help with their 2-point discrimination per se, but we know that they've got enormous problems with bimanual integration and trying to control movement. So hearing more about their story and using that as taking that into account when measuring something like tactile acuity. This is just my own opinion from the research and the work we've done, but that might hold more value than comparing to the other side per se.
And is there any change across the lifespan? So are paediatrics or younger adults treated differently? I know there used to be early case studies in the literature about being much more functional with them compared to adults, or is that not something you're aware of?
It's a really good question. I can't speak much on the paediatric side of CRPS. I've worked with adults only, and I'll also add I've really only worked with upper limb pain CRPS. I didn't set out to only look at upper limb CRPS, but it just happened that in recruitment of an early study, more of those came up, and we stuck with that. In terms of paediatrics, though, it seems that we need to pay more attention to CRPS of the lower limb in that group, and that might follow just kids are running around more, they're kicking footballs, etc. We're using our upper limbs more, or when we fall, we put our upper limb out and we break it, and a certain number of us go on to develop CRPS. But certainly being more functional with those kids, but those same messages around reassurance, around education and information would be just as pertinent, but definitely need to be targeted in an age-appropriate way, and really bringing the parents in. I mean, I'm a researcher, I don't work clinically, but not a week goes by actually where I don't receive an email from a parent, often in desperation, for their child. And so bringing the parents in on that education and empowerment, because going to the literature, going to Google and looking up complex regional pain syndrome doesn't leave anyone with great amounts of hope. It's pretty frightening. Yeah. So the onus is on us to help share the science and how to digest it. And
is there anything we can contribute to it in a negative way? And I mean that in the sense that we're seeing a lot more school children in clinic who have been put in moon boots, and they've kept those on, should have been say 2 to 4 weeks, and they've still got them on 3-4 months later. Because in a way they're scared to take it off. I don't know if that's contributing to CRPS, but definitely contributes to complex pain of their low limb, and it mimics CRPS. But is there anything like that physio should be aware of, that we can cause harm in the acute phase to almost prevent it?
Yeah, I can't speak to anything like splinting in particular, although that is a really interesting thing, I think, splinting and immobilisation of an injury. injury and surgery aside, splinting and immobilisation and the pathways that can take. Going back to the very first thing I said, actually, in terms of the way we speak about pain. So whether it's back pain or CRPS or anything, I think the way we speak about pain is really important. And I think a patient or someone living with pain or their family member, if this is a child, their parent, for instance, I think they're always on to us. If we're speaking about pain in a certain way in the acute phase, and then we change the way we speak about it because they've hit this sort of arbitrary 3-month mark. And I think they're onto us and they think they've been put into a different category, a bit of a too hard basket, and maybe they're on a bit of a trajectory to something bad. So I think if we speak about pain in a scientifically accurate but age-appropriate, layperson-appropriate way from the outset, surely we must help with them, allaying some of the anxiety and the fear that is understandable. I mean, I don't want to use the word catastrophizing because I think that implies that people are worried about something when they shouldn't be. So the anxiety and the fear that they're absolutely entitled to feel in these scenarios. But if we can bring them along with the science we know about and we're trying to keep on top of as we treat them, it's got to help. But I have to preface all that with I don't treat anybody.
Yes.
But I know that being a pain sufferer myself, the fear is real, the anxiety is real, and no matter what knowledge we have around it, we can catastrophize, and any information and education's got to be a good thing.
Great. And then circling back as a final thing to your research specifically, what are your main things you've gotten out of the research? What are your main findings? What are the main things you're finding are lacking that we need to look at?
I'm finding it quite exciting, actually, to look at the work in CRPS over the years. My PhD was focused on using functional MRI to stimulate the CRPS affected side and the less or non-affected side, and then look at the blob that resulted in the MRI and have a look at the representation, the functional representation of that hand in the brain. And less of that is done now, and some of it's come into question too. Lots of different techniques were used, lots of different things were found, and in phantom limb pain in particular, but also in a bit of CRPS, we've come to think, what does it all mean? And can we really sort of hang our hats on it? And I'm not sure. But I think that's science and that's natural. And I think that as we go a little bit deeper beyond the cortex, that's where things get exciting. It makes sense that we looked mostly at the cortex 20 years ago, even 15 years ago. But now finding things in the thalamus and in the brainstem and coming down to the spinal cord and really looking through the whole neuraxis, I think is really exciting, because we know that there's great somatotopic organisation of incoming sensory information throughout the whole central nervous system. I'm excited to move away from more of the cortical stuff, which we did ourselves, and question ourselves more on what is happening at the spinal cord level, what we can learn from the rat research. I just love sort of sitting back from it and trying to piece it together and see how much things have changed. And that's not to throw anything out, but it's just to add it all to this bigger picture that improves with more technology, better questions asked.
Perfect. Thank you.
Thank you.